Preventing heart disease can start today. And there are simple steps that you can take without a physician's advice, without taking medication, to really decrease your risk of heart disease. Engaging in a healthy lifestyle changes, becoming more active, and making some small dietary changes are things that you can do at home to really decrease your risk significantly of heart disease. The biggest misconception among women regarding heart disease is that they're not at risk for heart disease. They think they're at higher risk for breast cancer, uterine cancer, ovarian cancer, when the truth is, women above 35, the number one cause of death is heart disease. We're going to start off the night talking about why are we holding this event? Why do women need to know about heart disease? Kind of give a little bit of statistics and just let you know the facts about heart disease. The next thing is to define what heart disease is. I found this was a pretty elusive. The word is everywhere, but it doesn't really. I want to tell you exactly what heart disease is and what it means. Your risk factors, so that you know leaving tonight whether you're at high risk, low risk, or intermediate risk for heart disease. And then give you tools. I think we give you a handout as you walked in here to kind of give you a guide and some tools about how to have a conversation with your doctor. I think that's going to be one of the most important things that I want to leave you with tonight is questions to ask and things that you should know about your health leaving the conversation tonight. Again, kind of giving you an action plan about things that you can do, very simple steps to decrease your risk of heart disease. And then, this is kind of, I wanted to tell, especially the women in the group tonight, what signs and symptoms are of a heart attack, when you should be concerned, when you should call 911, when you should seek medical attention. So again, welcome to Woodlands. I say welcome, I've only been here for a month, but it's beautiful. And I hope you take the opportunity tonight to kind of walk around the facility and see everything there is to offer here. There's a hematology oncology group, urology, we have radiation oncology, breast health services, and that includes annual mammograms, DEXA scans for the women in the audience. You don't necessarily have to be a patient here, but it's available to anyone that wants to come in. And we have imaging and diagnostics. Any test that you need to have done, we can do here. And then Courtney mentioned we just opened up the primary care division, which is me. So let me take this opportunity just to kind of describe to you what primary care is and our philosophy and our mission here at the Woodlands. We stress a patient-centered approach. So what does that mean? That means that I view patients. Everybody has mothers and fathers and children and brothers and sisters. I want to treat my patients as though I were treating my mother, my father, my brother and sister. That's what patient-centered care approach is to me. So we stress primary care is a lot of prevention, education, kind of walking with you and coordinating care between specialists. So education, we do screening tests here, early diagnosis and treatment. This is kind of just a graphic showing the most common diagnoses that are made in an internal medicine office. You see hypertension, dyslipidemia, which is elevated cholesterol, diabetes, back pain, anxiety. We see a very, very wide variety of complaints, diagnoses, and problems, which is why I think it's important that when we talk about cardiovascular disease and heart disease, you're going to see your internist or your primary care physician before you see a cardiologist. And so really you want to be having this conversation with your primary care physician to make an early diagnosis before you have to see the cardiologist. So the heart truth. Heart disease is the number one cause of death in women. This is women above the age of 35. So heart disease kills more women than all forms of cancer: breast cancer, colon cancer, lung cancer, ovarian cancer. All forms of cancer combined, heart disease is still the number one cause of death. This is a big misconception among women that there's a lot of attention being placed on breast cancer awareness, which is good. It's good. But heart disease remains the number one killer of women. Again, you got a graphic here showing, this is in 2010, the number of deaths among women and the cause of death. You see heart disease, and this is all forms of cancer combined. Again, we're talking about women past the age of 35. So this is not necessarily a young woman's problem, an older woman's problem. It's all women over the age of 35. And you see, this is, again, there's within women, there are some disparities. So Black women, women of African descent, compared to white women, and then Asian women, there are higher numbers of black women dying of heart disease, but irregardless of race or ethnic background or socioeconomic status, heart disease remains the #1 cause of death among women. All right, and then again, specifically talking to women, after you go through menopause, your rate or your risk of heart disease triples. Right? Another graphic showing this is women, the ages of women. So women in the age group of 35 to 44, you can see there's not a very high number of cases of heart disease. As women progress through age, you see this number, the red is women, the white is men. So you see there's a very small number here. As we go through menopause, the number triples, begins to increase, and then women overtake men over the age of 75. But you can see that as age progresses, really around menopause is when the risk increases. So why does this happen? As estrogen levels drop, there's two types of cholesterol. There's good cholesterol, the HDL you've probably heard. HDL cholesterol decreases. The LDL cholesterol, which is the bad cholesterol, increases. And then weight increases as when we go through menopause. These three things combine to increase your risk of heart disease. Now, that being said, up until around 2-3 years ago, there was a lot of uncertainty about whether or not women should be taking hormone replacement therapy. In fact, up until around 3 years ago, there was no consensus statement, and a lot of OBGYNs were told, these kind of the guideline practices were to prescribe hormone replacement therapy to prevent heart disease. This is not the case. Hormone replacement therapy increases the risk of heart attack and stroke. This is a study called the Women's Health Initiative. There have been multiple women's health initiatives. This has been well studied over the past 20 years. It's now clear that hormone replacement therapy can increase your risk of heart attack or stroke, as well as breast cancer, breast cancer and blood clots. So, we'll answer questions at the end. I don't want to tell women one way or the other. Leaving here, you should know that if you're taking hormone replacement therapy to prevent heart disease, then that's old data. So whether or not you're taking it is a different story. Everyone has indications, but to prevent heart disease is the wrong reason to take it. Now, going forward here, women, heart disease can be a very debilitating and time-consuming disease. So preventing it and treating it early is going to allow you to lead a healthy, fulfilling life and really enjoy everything that you enjoy about life with your family. So what is heart disease? Kind of defining what this is. Now, there's coronary artery disease, which is probably the most common form of heart disease. And I'll show a graphic here in a little bit, but coronary artery disease is disease in the blood vessels that supply blood to the heart. That's what coronary artery disease is. Heart failure is usually a consequence of multiple heart attacks or advanced coronary artery disease. And this is when the heart is a pump, pumps blood to the rest of the body. Heart failure is when that pump is not working well. So, I can answer specific questions at the end of the talk, but heart failure is when the pump is not working as well as it should be. Arrhythmias, I'm sure you've all seen commercials on television, atrial fibrillation. That's what an arrhythmia is. It's an abnormal heartbeat it's an abnormal heart rhythm in the heart. Valvular disorders, some of these can be, there are a lot of reasons valvular disorders can occur. I'll just say a number of valvular disorders that are pretty common. There's mitral valve prolapse, there's mitral valve stenosis, aortic valve prolapse. These are valves, there are 4 chambers in the heart that are connected by valves. If those become diseased, can be a problem. So all of these, we talked about the disease to the vessels in the blood, the vessels in the heart that supply blood to the heart. What happens is over time, these blood vessels become diseased. The heart doesn't get enough oxygen, doesn't get enough nutrients, it becomes weak, and it can become damaged. This is a process called atherosclerosis. Okay? So this is a normal blood vessel. Can everyone see the laser pointer up here? Or would it be best if I just... This is a disease process called atherosclerosis. And atherosclerosis is when blood flow through the arteries, for whatever reason, becomes turbulent. And so the lining of this artery, this is called the endothelium, the lining of the blood vessel becomes damaged. It becomes opened. And then over time, you have the development of what's called a plaque. This is, to a large extent, the LDL cholesterol forming this plaque. Now, there are other types of cholesterol, kind of called low-density particles, that are probably more plaque formation, but this is bad cholesterol forming a plaque in the artery. This is the basic mechanism behind heart disease. These formations of plaque largely in the vessels that supply blood to the heart. The consequence of this over time can be a heart attack. And so what happens in a heart attack is you have, this is a picture of the heart. This is what's called the LAD, or this is the biggest blood vessel that supplies blood to the heart. Coming down here, you have this plaque that's been forming over the course of many years, and for whatever reason, this plaque ruptures and blocks off blood flow to that area of the heart. And you can see the area in black down here. Once blood flow is blocked off, this area of the heart it's at risk. It becomes it can become permanently damaged, or at least reversibly damaged, depending on how quickly you seek attention. But this is what happens during a heart attack. So I want to make sure that the mechanism behind heart attacks, this plaque formation, takes place over years. The heart attack is a consequence of this plaque being formed and then breaking. So there are multiple therapies when someone is having a heart attack or has had a heart attack. We're very good about trying to fix the damage to that blood vessel. So you've heard of maybe you've had friends or family members that have had a cardiac stent placed. This cartoon right here is talking about what happens. So you have this blockage in the artery, this plaque formation. You can see the green lines. This is blood that's not efficiently getting through that blockage. And so the problem is that the area in front of that, behind that blockage, is not getting good blood flow. Now, a stent comes in here and opens up that artery. The same thing is with a CABG, or what's called a coronary artery bypass graft. So the surgeons will be able to take veins, connect them to your aorta, and actually just kind of go around that blockage. So this is just kind of a picture of what these therapies look like. Now, I want to stress, these can improve blood flow to the heart, but the damage, some damage will already have been done. So once these therapies, these are very necessary therapies. I don't want to discourage anybody from having these done, but the idea of this talk is to teach you, or to kind of give you information about how to prevent this damage from being done to your heart. Because once you have to have the CABG, once you have to have a stent placed, then you already have coronary artery disease. So at that point, you're very, very high risk. But this talk is to how to prevent this from happening. Again, so one of the most important thing we talk about with patients, patients, they really ask me, do I have to take medication? I'm going to say the first step to preventing and treating heart disease is really making a change in your lifestyle. Okay. Exercise, a diet to improve your heart health. Now, are medications necessary? Yes, sometimes medications are necessary. But the backbone of treatment of core heart disease and diabetes, high blood pressure, is lifestyle management. All right. Why? Now I see a lot of women here, some men. Why? Why should you be here? Why are you interested? So young women, this is the women, they say below the age of 40. This is really a good time to develop these heart healthy habits, getting into a good exercise routine, developing kind of a taste for these heart healthy foods. Women in the age of 40 to 60, this is when you're at highest risk for the development of heart disease. So this is very, very important for women in the age group of 40 to 60 to really pay attention to these risk factors, reverse risk factors if they are present, to really improve your heart health in the future. Women above the age of 60, it's never too late to start. Right? This is important to be here. Women and men are living much, much longer, so it's never too late to make these changes. I want it to be also clear that women, now this is something that the medical profession has to look very, very deep at its practices. There's a very big disparity in testing for cardiovascular disease and treatment between men and women. So women receive far less lipid screenings. They're far less likely to be prescribed an aspirin or a beta blocker after a heart attack. They're far less likely to have a stress test ordered. They're less likely to have a defibrillator. There are a lot of things that women are less likely, treatments that they're less likely to receive, tests they're less likely to have ordered. And why that happens, we'll determine that. But being aware of that is important because it's going to be incumbent upon you women in the audience to be proactive and to have questions ready for the physician. Say, should I have this test ordered? Should I have this medication prescribed? So these are the questions that I'd like you to answer. That the handout that we've given you, I want you to kind of take that to heart because this is a problem, and the medical profession is trying to address this, but it's real. Now, risk factors for heart disease. So who's at risk in the audience here? There are two categories of risk factors. One are things you can control, and the other, which we'll talk about here, are things that you have no control over. A family history of heart disease. So if you have a first-degree relative, meaning a father, a mother, brother, or sister, who has had a heart attack or heart disease diagnosed early in their life, and by that I mean a female, so a mother or a sister who's had heart disease diagnosed before the age of 55, or a man, meaning a father or a brother, before the age of 45, then that's a risk. You're at risk for heart disease. The other one is age. So as men over the age of 45, you're at higher risk. Women over the age of 55, you're at elevated risk for heart disease. A history of preeclampsia. This is relatively new, but if you had preeclampsia as a woman, you're at higher risk for heart disease. These are things that we can reverse now, right? Smoking, high blood pressure, dyslipidemia, which is elevated cholesterol, obesity, overweight, physical inactivity, meaning less than 150 minutes a week of exercise, diabetes and prediabetes, the metabolic syndrome, sleep apnea, stress or depression. These are risk factors for heart disease which through either medication or lifestyle changes can be changed and decrease your risk. So what are some tests that, and these are things that when patients come in to see me in the office that I really stress, and I want them to, we give you a piece of paper. These are numbers that you should know. Everybody in the audience should know and have these tests done. Blood pressure. Once a year, you should have your blood pressure measured to see if it's normal, then that's fine. You wait one more year. But if it's not normal, you should have it rechecked. Your cholesterol. You should have your HDL, LDL, and triglyceride levels checked. Now, the frequency depends on what your risk factors are and what your other comorbidities are, but you should know these numbers. These are numbers that we've given you a handout. Kind of keep track of them and make your own numbers so that you know what your risks are. Diabetes. After the age of 45, all adults should be tested for diabetes at least every 3 years. The prevalence is so high in America that if we can diagnose it early, we can do some lifestyle interventions to treat it, but adults over the age of 45, every 3 years should be tested for diabetes. Whether or not you have it, every 3 years. The body mass index, this is it's a calculation based on your height and weight. So you should have your weight checked at least once a year. Electrocardiogram. Now, these tests are not necessary for everyone, but this kind of depends on your risk factors and what your physician decides. And then a cardiac stress test. These are all tests that could diagnose heart disease. So now, kind of walking you through the checklist we gave you, questions to ask your physician. I understand this. I've gone to physician visits. I've been a patient in my own, with my family members, my wife. Sometimes it's a little bit overwhelming. When you're meeting a new physician or you have a lot of things on your mind, oftentimes the physician has questions that they want to ask or things that they have to get done. And so oftentimes the conversation is difficult to have. So I urge you to really find a physician that you feel comfortable with, you can have a conversation with, and that you feel that your concerns are being addressed. And the best way to do this is to really be prepared when you go to see the physician. Just like you were going to a job interview or you're going on a first date with someone, you want to make sure you have a list of questions and then things that he or she will ask you. So medication list, knowing what your medications you're taking, either having them with you physically or bringing a list, knowing a little bit more about your family history, particularly how your mother, father, if they are living, if they have heart disease, if they are not, if they died of a heart attack, and then questions. And we have the questions in your handout, but these are questions that you should really leave an annual physical with, or if the visit is specifically about your cardiovascular risk, these are questions that you want to have answered. And then take notes. Take notes. That way you are not necessarily, you don't have to have everything memorized. You take notes, and that way when you go home, if you have other questions, then you can come back in and be more prepared. So, talking about the tests that you should have done at least once a year, or however frequently, to test to see if you're at risk for cardiovascular disease. A blood pressure. A normal blood pressure is 120/80. Now, we like to start medication, or at least really stress lifestyle modification if it's above 140/90. And the reason is this. This is a blood pressure of 115/75, excuse me. You're at really no risk, no increased risk for a heart attack or a stroke. As the blood pressure creeps up, 135/85, your risk doubles. As it gets up to 155/95, it quadruples. As it gets up to 175/105, 8 times the risk of a heart attack or a stroke. So it's, as a primary care physician internist, I don't enjoy prescribing blood pressure medication. I don't go home and brag to my wife about how many patients I gave blood pressure medication to. But the idea is I want to decrease your risk of a heart attack or a stroke. So making sure your blood pressure is controlled is a very, very important thing. And I tell patients, this is not, blood pressure being high is not something you notice or something that affects your day-to-day life. So if your blood pressure today is 155/95, that's not going to cause you to have a heart attack or a stroke. If it's 175/105, again, probably not going to cause you to feel necessarily poor. But the risk is that high of a blood pressure over the course of 10 years will cause heart disease. It will cause that damage to the small blood vessels that leads to a heart attack. So these are things that, they're small details right now, but they can be big, big things down the road. Cholesterol. Now, cholesterol levels and your goal cholesterol is really, it depends on your risk factor for heart disease. I put up here, these are very, very strict blood pressure goals. These are kind of the ideal numbers for patients to eliminate the risk of heart disease. The LDL number right here of 100, this, again, is a pretty aggressive strategy to prevent heart disease. This is ideal. Some patients don't necessarily need to be treated this aggressively. If you don't have many risk factors for heart disease, an LDL number of 130 or 160 may be tolerated, may be acceptable. So this really depends. You have to really talk with your physician about what your goal cholesterol should be. But this LDL number is we call ideal. Now, the HDL in women, this is the good cholesterol. We want to get it above 50. And we'll talk about strategies that you can take on your own without medication to get your HDL cholesterol up as high as you can. The triglycerides below 150, it is what it is. Now, sometimes physicians will calculate what's called a non-HDL cholesterol. This is what we've realized over the course of the past probably 5 to 10 years is that sometimes it's difficult for patients to have blood drawn when they're fasting. If you come to the physician's office, you may have had to take it off work, you may have had to find daycare, you may have had other obligations. To have to come back in a second time when you're fasting for blood work is sometimes inconvenient. And so what we can do now is we can draw cholesterol at any time of the day and still give you your cholesterol goals in order to decrease your risk of heart disease. So again, another point to take home, you don't necessarily have to be fasting to have your cholesterol checked. Don't pass over an opportunity to have your cholesterol checked because you're not fasting. Have it drawn when you're at the doctor's office. Diabetes. Now, the diabetes is in and of itself what we call an equivalent of heart disease. So if you have diabetes, you are at high risk for heart disease. And so having your hemoglobin A1C, and if the hemoglobin A1C is what we use we used to use it just to follow the progress of diabetes. Now we can use it to actually diagnose diabetes. It's an average of your blood sugar level over the past 3 months. So if you have diabetes, you want your hemoglobin A1C to be below 7. If you don't have diabetes, you want it to be below 5.7. And you can see here, this is just a graphic. This black dotted line are women with diabetes, and the red line is women without diabetes. And the line down here is, as time goes forward, you can see as time goes forward, the number of women with diabetes, the risk of death due to heart disease is much, much higher. So diabetes is serious. I treat it seriously. You should treat it seriously. If you have diabetes, we really want to get your hemoglobin A1C below 7. Weight. Discussing weight with women is never an easy issue. Yeah. But weight is really, really important. And not necessarily, it's important for heart disease, but really being overweight, it just makes it difficult to really engage in physical activity. You'll develop arthritis, your knees will hurt, your back will hurt. So being overweight is really, I tell patients this. If you're overweight or you're obese, that weight didn't come on in 3 months. Right? That weight has been gained over the course of years, and it's not going to come off in 3 months. So I think for me it's important to tell women, just to kind of make the diagnosis, measure your BMI. Don't be ashamed or don't be afraid to know what your weight is. Right? Know what your weight is, know what your BMI is, and come up with a plan to gradually and slowly decrease the weight. You can see that this is a BMI is basically your height over your weight. And so it's what we use, it's your weight over your height, pardon me. It's kilograms over meters squared. And it's what we use to classify either underweight, normal weight, overweight, or obesity. And so if you can, this line right here is either normal weight or underweight, normal weight right here. So you can see this, the BMI, if you're at a normal BMI, your risk for heart disease, death from heart disease, is really not significantly increased. As you become overweight, you're 3 times more likely to die from heart disease. As you become obese, 6 times more likely to die from heart disease. So weight is important. And then now we're going to talk more about tests. So just to kind of give you the terminology so that you feel comfortable talking with your doctor. We use these terms kind of interchangeably. There's EKG or electrocardiogram. This is a test. This is what the printout looks like. What this test is it measures the electrical activity of your heart. Can everyone see? I'll come over here. So the EKG, it measures the electrical activity of your heart. And this is a very simple, non-invasive test that can be done in the office. It takes about 5 minutes to do. You have to remove your shirt or your bra, and the electrode, you just place some sticky electrodes on your heart. Take basically an electrical picture of your heart. The information gained from an EKG is very, very valuable. We can diagnose arrhythmias, so an abnormal heartbeat. We can diagnose each of these areas of the EKG correspond to a different part of the heart. And so based on abnormalities in the EKG, we'll be able to see if there's a certain area, a certain blood vessel that may be at risk. Also, we can see if you have long-standing hypertension, we'll be able to see if there are signs that your heart is at increased risk of having a heart attack. And so the EKG is, if you have, an EKG is a very basic test that I would strongly urge you to ask your physician. If you don't have an EKG or if you haven't had one done in the past year or two, it's one test that could be done. Now a stress test that, I think, I'm not sure who I was talking with, I asked them if they'd had a stress test and they said, I have 3 kids, what do you think? So and this really is, we talk about a cardiac stress test, it's the equivalent of, raising 3 kids. We get you on a treadmill. There are ways to do a stress test, but I'll tell you the best stress tests are one that combine exercise with imaging. So I'm sure you've heard of what's called a nuclear stress test or a stress echo. Those are the best type of stress tests because they allow us to see how your heart beats at its maximal, at its maximum. So we want to get your heart rate up to its maximum. Have you really stress your heart to see how it beats. And then also we'll be able to image it either through a nuclear stress test or stress echo and see if there are parts of your heart that don't beat normally or don't get adequate blood flow at peak exercise. So a nuclear stress test, which we do here, we offer here, basically it's a CAT scan machine. Now the way this is done is you take images of your heart when you're at rest, and then you exercise on the stress test. If you, for whatever reason, can't exercise, if you have severe arthritis, you're not comfortable on a treadmill, then we can just lie you on a table and give you medication to speed up your heart rate. So exercising is not necessarily important. And then we would re-image your test after you've exercised or after your heart rate has been accelerated to see if there are areas of the heart that aren't getting blood flow normally. So why don't women take action? After we have this talk, what are some of the reasons that we've studied that women don't take action? One is there is a misconception that heart disease is really just a man's disease, that breast cancer and other types of cancer are really the things that women need to worry about, which is false. We've talked about that. Heart disease is the #1 cause of death in women, so this is definitely a women's disease. Now, the other reason, and I run into this frequently, is that women, you have children, husbands, parents, a home life to worry about. Women really have so many responsibilities in their life that they oftentimes make themselves less of a priority. They don't necessarily seek medical attention when they should. So, and the other thing is that this misconception that if you're not above, maybe you're not old enough to be at risk for heart disease. We talked about after the age of 35, the #1 cause of death in women is heart disease. So everyone, I'm looking around the room, maybe except for the young man over there, everyone is at risk for heart disease. Too busy. Now this is something that our staff and I think all primary care physicians, cardiologists in general, we want to make our schedules convenient. I understand women and men have work responsibilities. They have a lot of responsibilities. We offer evening hours here. We're going to offer weekend hours. You really seek out medical attention. Make it convenient to you, but really seek medical attention. They're already feeling stressed, and they don't want to necessarily know or be told by a physician that you're overweight, that your cholesterol is high. These are the things that I hear every day in the office. That's fine, but I think, to me at least personally, not being stressed about something and not being able to talk about it with someone makes the stress even worse. All right? So again, I urge you to really seek a physician or a care provider that you feel comfortable talking about this and having a good conversation with. Tired. Everyone's tired. Now, again, I want to stress to you, you are a top priority. Heart disease can be, if diagnosed early and even if it's already present, can be treated and it can be improved. Right? Take care of yourself. Everyone has, women in particular, have a very big role to play in their families and society. You won't be able to play it if you're not healthy. So you need to make yourself a priority. Take the time, dedicate it to yourself. You owe it to yourself. Now, we'll talk about healthy lifestyle changes. I'm going to give you a few things when you leave here that don't take much time. And I don't talk about diets. I don't talk about joining a gym and an exercise program. What I want you to focus on are heart healthy or healthy lifestyles. So small changes that are easy to make and can make a big impact in your overall health. And one more thing. As you do this, it's important. I see a lot of people here, women here with their family members. It's important that you make it something that the whole family can participate in, so that it's, one, you're held responsible, you're held accountable, and two, have your husband or your significant other or your children benefit from your healthy decisions. So kind of just talking about, again, switching gears now to things that you can do to improve your heart health, to decrease your risk of heart disease. Exercise. Now, when I say exercise to a patient, I think automatically they envision me asking them to train for a marathon. Right? That's not the case. In the next slide, we're going to talk about simple activities that are exercise. What I want to stress here, these are the number of hours per week engaging in exercise, the number of hours per week, and then the risk of heart disease. So if you're doing 1 hour a week of exercise, you're not decreasing, you're at risk for heart disease. You're not decreasing your risk. You're at equal risk. If you do 2 hours, all right, the risk of heart disease drops by 20%. 3 hours drops by 65%. 4 hours drops by 60%. 5 hours a week, which is the recommendation, cuts your risk in half. So what do I mean by exercise? 30 minutes of activity, 5 days a week. Now, walking, you're dancing, as this couple is doing on the beach. If you're dancing to a song that you enjoy, you do 3 songs, that's 15 minutes right there. Right? At home, dancing in the shower. If you're walking, we live in Pensacola, if you live in Gulf Breeze, walking along the beach. Now, you want to get yourself to a point where it's not comfortable to carry on a conversation. The idea of measuring your pulse, your heart rate to determine your level of activity, I find that a little bit cumbersome. It's easier to just say you're doing enough exercise where you don't feel comfortable talking about the weather. You can say, give me a glass of water, watch out for the dog crossing the street, but you're not carrying on a conversation. So there's bike riding, walking the dog, which is what I do. My job is to walk the dog in the morning and the evening. That's how I get my exercise in. I'm new to Pensacola, but my wife joined a gym at Pensacola. I'm not sure if anybody's heard of this. They have a really excellent program dedicated to women and women, or I guess adults in general. Exercise programs there. Diet. Now, I'm going to put up 2 diets. Two diets here. And I'm not sure, can everyone see this? I'll kind of walk through the slide here. I kind of want to look through the diet, and we'll walk through it here together. So the diet on the left here, and this diet recommends taking more than 4 tablespoons a day of olive oil. Tree nuts, peanuts, 3 times a week. Fresh fruits, vegetables, fatty seafood, 3 times a week. Legumes legumes, which would be lentils, other types of food. They're telling you to eat white meat, drink 7 glasses of wine a week. All right? Yeah. Right? The soda drinks are discouraged to less than 1 a day. Commercial baked goods, so if you go to Publix, stay away from the baked cake, or at least just have less than 3 times a week. Spread fats, which would be butter, margarine, mayonnaise, less than 1 a day. Red or processed meats, so lunch meats, less than 1 a day, compared to a diet over on the right hand. So low-fat dairy products, whole grain food, so whole grain breads, whole grain rice, whole grains, fresh fruits more than 3 times a day, vegetables twice a week, lean fish and seafood. And this diet says no vegetable and olive oil. Any visible fat in meat and soup, cut it out. No fat. No nuts and fried snacks. No soda drinks. No commercial baked goods. No spread fat. No red processed meats. No wine. Now, which diet do you think had better outcomes in terms of cardiovascular health? Yeah. All right? Because of the wine, right? So this is the typical low-fat diet that's prescribed most often for heart disease. This is what's called the Mediterranean diet. This was a study that came out about 6 months ago in the New England Journal of Medicine. It really kind of changed. This was, had a lot of media coverage because this really kind of turned all the dietary recommendations that we have been giving to patients for the past 15 years on its head. This was a study done in Spain over the course of 2 years. They followed 6,000 adults, and these were not adults that were marathon runners or Olympic trained athletes. The majority of them were females. About 60% of them were females. The majority were overweight or obese. But 82% had hypertension, 50% had type 2 diabetes. So these were not what you would, the models on television that are out running around, in the gym attire. These are what we would call a very representative population. 30%, so in terms of the Mediterranean diet versus the low-fat diet, the Mediterranean diet had 30% less heart attack, stroke, or death. They had to stop this trial early because people in the low-fat diet they were having heart attacks and strokes at a much higher rate than the group in the Mediterranean diet. So, going forward here, everyone, I'm not going to sit here and tell you that you need to follow the Mediterranean diet and drink 7 glasses of wine a week. What I want you to do is have a conversation with your physician. Everyone should be, your diet should kind of be based on your health risk and your other comorbidities or other lifestyle changes that you have. But what I stress in my patients is I don't sit there and tell you to not. All right? This diet has a lot of very good, healthy, tasteful foods. The idea is when you leave here, I'll tell you where to find this diet. It's called the Mediterranean diet. You just search it in Google. But pick out foods and recipes from this diet that you enjoy, and really add those to your diet. I tell patients, I'm not going to sit here and tell you to not eat fried foods. What I'll sit here to do is, when you go to a restaurant or when you're at home, fill up half of your plate with green, crunchy vegetables and tomatoes. Eat that first and then eat whatever else you want after that. But the idea is to add healthy foods to your diet, foods that will promote good heart health, and the rest will take care of itself. All right, again, kind of wrapping up the talk here, I want to talk about signs, particularly in women, of a heart attack or a stroke. And so everyone knows the idea of chest pain, but women are more likely to have called atypical symptoms of a heart attack or a heart attack. So instead of having a really sharp chest pain, you may just have squeezing. You feel short of breath. You have kind of in the middle of your chest squeezing. You could also have, instead of squeezing in your chest, you could sometimes, I've known women to have the pain that radiates to their shoulder. Excuse me, you just not feel well. You'll feel nauseous for no particular reason. You'll feel just not well. There's no, and especially in women, there's no one symptom or sign that knows you're having a heart attack. All right? What I want you to do is, if you think you're having a heart attack, call 911. Or if you're not sure and you come into your doctor's office, but do it that same day. Only 53% of women in a survey, if they asked women, if you think you're having a heart attack, how likely are you to call 911 to seek medical attention? 53% said they would for themselves. Now, ask that same woman, if your neighbor, if your friend, who's a girl, is sitting next to you, if they said they might be having a heart attack, would you call 911? 80% said yes, they would call 911. The same signs and symptoms, and their friend or family member, these women would call 911, but for themselves they wouldn't. So, bottom line, if you think you're having a heart attack, call 911. All right? I can't sit here and tell you what's exactly going to happen, but if you think it's happening, seek medical attention. All right? Minutes count when it comes to a heart attack. You don't want to sit at home and wait. So, there's the proverb that the longest journey, the journey of 1,000 miles starts with one step. So this is, drawing kind of a line here. I want you all to come up tonight, talk to your significant others, think about yourself, steps that you can take to really improve your heart health and your heart outcomes. Again, focus on developing healthy lifestyles. So, coming up with an exercise plan or an activity plan, coming up with certain foods that you want to start adding to your diet. Get moving. All right, let's get moving. Good. All right, thank you all for coming. Yeah.